start things off. Just get a sense. Who knows how that whole process works right now? Like, who could just give me a 2-minute summary or 1-minute summary of how health insurance works, how your premium works? Who could do that right now? Raise your hand raise your hand if I should just stop talking right now. Okay, we have 2. I think 3.
You're asking for a volunteer, or if we already know that?
Let's ask if you already know it first, and then I'll pick a volunteer. And since you volunteered. Would you like to give your 1-minute spiel on what you think?
Sure. I'm actually from the UK, so I'll actually give a funny story to start, if I can take an extra 30 seconds.
Yeah.
I moved from the UK that had socialized medicine about 16 years ago, and I worked at a small company called Genentech. And it took me 6 months to figure out that we did not have socialized medicine. because the compensation package was so good, right? I had no co-pays, no premiums. And it wasn't until I started talking to a friend who was complaining about paying to have a crown done. I'm like, what do you mean you pay? Good. My doctor, I don't have to pay a thing, right? And I realized, so, payers. They actually are the health plans, and what they do is they really are the sort of the administrator, the middleman between you and anyone who provides a service for you. So a service is going to the hospital, going to the doctor, going to the emergency room, having a prescription. The payers negotiate prices with all of those, right? And then they negotiate with your employer or with you if you're an individual that says, here's the premium that I want you to pay, right? And so it's like your house insurance. You're going to pay me a small premium. Sometimes you're going to pay copay to go to the doctor. And if ever you have a heart attack, right, or end up in a car crash or have cancer diagnosis, I will then cover those complete costs. And the payers are the people really that sit in the middle and work out those contracts with the payers, with the providers, the hospital systems, what they're going to pay.
Cool. Do you want to switch spots? That's pretty much it's your turn right now. But no, that was actually great. Thank you so much. I'm just going to jump into this then. So, I mean, this is basically what you described, right? Where, a payer acts as that middleman, interacting both with patients, with employers, but also the providers, and coordinating all of the fees and services around that. I think this kind of symbolizes the overall kind of generic template for how this works, where, as a patient or, as an employee, you pay both a copay to your providers, but also a monthly premium, usually taken out of your paycheck. In addition, your employer also tends to pay a monthly premium or annual premium to the health plan itself. From there, whenever you get a service from a provider, that provider will now submit a claim over to the health plan. The health plan will evaluate whether or not they're going to pay it in full or what portion they're going to pay, and use both the funds that you paid out from the premium aspect, but also everything that they've collected to ultimately kind of pay off the claim and kind of facilitate that whole process and facilitate the financial transactions. Once again, this is also supposed to be more of a discussion. I know we have lecture slides, but just interrupt me, do whatever.
So, do you want to comment a little bit about actuarial, like how you price based on where you can go?
We'll get into that a little bit more, right, in a bit. But we'll try to give as much knowledge as we can on the actuarial process. I mean, we're not experts in that field, but yeah, we'll dive into that. So payers are generally segmenting the market by age group, both from a group and individual perspective. Yeah, you stay over there. You're just kind of staring at me right now. So when we look at the group aspect, that's when your insurance plan is actually interacting with large and small employers. That's how they categorize the different products that they give you. That's also how they end up pricing things in the end, depending on the size of the group. Because what ends up happening is that depending on how large that employer group is, that'll dictate what the shared cost and the shared risk will be. So that's why if you work for a larger plan, you tend to have a better insurance price versus if you're working for a small employer where you end up paying a higher premium and higher copays. It's because the risk level at that smaller group level is much higher. So as a health plan, you're constantly trying to balance risk and premiums and really what the market will bear in terms of costs. The other aspect of that is the individual market. So the individual market is usually divided into the over 65 group, which is the Medicare group. And more often than not, the health plan actually isn't really providing a product around the, I think, over 65 group. They're really just kind of facilitating the Medicare products and the Medicare processes that are going on. They're administering a lot of that. For the under 65 group, that's where the private exchanges or private and public exchanges kind of come into play. And those types of plans tend to be more, let's say, risk heavy and put more risk on the individual themselves. So it's smaller coverage. They don't really allow you to go to as many providers, so it's a much more limited product on the individual side. But what you're seeing on all of the public exchanges, those are the individual products. Payers themselves are kind of segmented in 3 different ways. One is the managed care organization, so that's just all of the insurance plans that you're familiar with right now. All the private plans kind of fall under that managed care organization group. The government payers are Medicaid and Medicare. So Medicare is once again for the over 65 group. Medicaid is more for the poverty sort of disenfranchised segment. There's a certain poverty line, I think, for you to qualify for Medicaid. I forgot exactly what that.
From the state now, if they did the expansion or not?
Yeah.
Most of those states that did expansion, it's 200% of the
and it actually comes up with a kind of an interesting piece of the whole Affordable Care Act, is that there's still that pocket in between where you're covered by the public exchange, where you're covered by Medicaid, but there's this subset kind of in the middle where you're not getting any subsidies at all. And that's, I think, going to become a larger and larger issue, I think going forward. But that's more of a policy discussion that we have at another point. The other kind of big group, or the other interesting segment that's been growing a lot as of late, is the self-funded employer groups. So that's a situation where you have a very large employer. They're really not using the insurance plan to kind of manage their risk anymore. What they're using the insurance plan is just to administer the contracts, administer the fees, but they're bearing all the, like your employer will now bear all of the risk. So a lot of the large sort of national companies are kind of going down this path because they're realizing that it's cheaper than if they were to go full force with a insurance plan. Pause here. Cool. Okay. So when looking at the 3 different segments, typically fall.
I'm sorry, I just had a question in the previous slide. When you say managed care, are you talking about private insurance companies?
Yeah, that's all the private insurance companies are there. So
why is it called managed care?
I know that was a term that came up in the 60s, right? Like that's when the whole concept of HMOs and managed care kind of came about. Really, I think that the concept is that your insurance plan will help to kind of manage your health and manage the risk around the services you're getting and kind of directing that a little bit more. So I think that's where the term came up.
And also, in that case, you have a primary care provider who is sort of like the gatekeeper. Instead of just you hurt your back, you go to a specialist. The primary care person manages that and checks you out first, and then that doctor recommends a whole host of services, and it's to keep people from just going to the higher paid specialists to get their care. So it manages that better.
So when looking at the managed care organizations, they're usually divided up both either as a national plan, so that's the large ones like Cigna, Aetna, United, or the regional plans. And that includes Blue Cross Blue Shield of MA. So I guess you're going to delve into the Blue Cross Blue Shield concept. But a little preview is that there are multiple Blue Cross Blue Shields across all of America. They're all actually individual entities. But they're bound together kind of by this association, and where they have kind of similar rules. You're able to see, or you're able to access healthcare across the various states. Even though I'm actually Blue Cross Blue Shield of California, but I live in New York, and I'm still able to get all those services. And it's because they're able to interact with each other, versus a national plan where that's just kind of set in the actual plan. So there's no regional aspect. What else is on this slide? Yeah, one thing with the national plans is that because they're so large, and because they can bear a little more risk, they tend to work more in the innovation space. I know, was it Cigna or was it Aetna that had like this whole big, was it Aetna that had like a recent kind of an innovation push, and I think the Association of Blue Cross Blue Shield is kind of trying to move towards that direction as they start to consolidate and kind of work with their Blue Cross Blue Shield affiliates.
Alex, I think it's worth mentioning that the nationals are all for-profit.
Yeah.
The Blues were traditionally started as not-for-profit. I think about half of them actually have now gone for profit, but it was
Yeah, a good chunk are still.
And I believe Blue Cross Blue Shield Mass is not-for-profit, right?
Yeah. Actually, I'm trying to think which ones are actually for-profit. I know WellPoint is.
Well, it's basically some of the ones that started. So the ones that compete with the Blues are for profit. I can't think specifically off the top of my head besides WellPoint. But WellPoint operates in 17 different states now.
But the ACOs are also for profit. There's one here locally, something like Big Buy Asphalt.
Oh, interesting. Great. So delving a little bit more into the products, and this actually might answer some of your questions about managed care. So when you look across the different products, you're really just kind of balancing two things. It's either cost or flexibility. And flexibility in terms of who you can see as a provider, what is actually going to be reimbursed, how much the plan is going to try to direct your care. Like all of that is kind of in that flexibility. So when looking at the lowest cost plan, so the HMOs, the high deductible health plans, more often than not, you'll need a gatekeeper. So as you mentioned earlier, your PCP, your primary care physician, will be the one who will recommend you to a specialist. Like you're actually not able to go to a specialist on your own. Or if you do, you're going to pay the full cost of that. So the reason for that is now, your health plan will have very specific contracts with specialists, with PCPs, and will be able to kind of direct you towards their network of contracted physicians. And it's all in the effort to both manage your health but manage costs at the same time. It's kind of a dual purpose here. And kind of as you go down the list, from point of service to the PPOs to just traditional, they cost more and more, but you get more and more flexibility. You can start seeing anyone you want. You don't need all the gatekeeper restrictions, and a lot of the copays and deductibles start going up as well as you kind of go down that list. Pause here because this is probably kind of a complicated slide, so I'll let you guys ask any questions.
Yes. Service.
So it's a product that I feel is kind of losing favor. I haven't heard as much. I think more often than not, plans are either offering the HMO high deductible plans or the PPO plans. Those are really the two big products that they're kind of moving away from point service. Any other questions about products? You guys are so quiet. So this is just kind of the breakdown of how your insurance plan actually makes money. So, sorry, you look like you're going to say something. So they take in all this premium revenue, both from the employers, but also from the employees themselves. What their true expense, what the largest expense that they have, that any health plan has, is actually paying out the claims. It's just kind of a known thing, and that claim payment and that reimbursement is all set up in the provider contracts that they've set up with all the various networks. There's usually a very small amount for administrative expense, and then what's left is the actual profit or operating income that the health plan will actually have.
And one thing to note here, this is illustrative. It's saying you have basically 10% is offering income. That's really generous for a health plan. I'd say more often than not, you're looking at 3 to 7% max. I haven't seen any health plans have 10%.
Doesn't the state of Massachusetts, like if Tufts charge too much and pay too much,
yeah, so
the loss ratio gets...
That's what the medical loss ratio is.
Right.
Yeah, so 80% of premiums need to be spent on administrative claims. and then the rest can be for admin expenses and profits.
Who dictates that 80%? Who dictates that 80% max?
Government. That's part of the health reform.
Is it a state-by-state variation? Is there a state-by-state variation, or is it federal law?
I don't think so. I think it's federal.
I feel like it's federal law.
So can you talk about, so for people providing solutions that are helping plans manage this MLR, can you talk a little bit about how that's thought about in this context? So if I'm providing a solution that helps manage administrative costs, and they're already pretty efficient, is that?
How's the payer?
Yeah. Versus if I, we provide something that reduces healthcare claims, reduces healthcare claims. So can you just talk a little bit about that? Like how different types of solutions?
Yeah, so just at the top of my head, I think plans are much more interested in reducing claims costs, so it's keeping people healthier, reducing the amount of expenditure they actually have to pay back out to the provider side, then reducing admin expenses. Admin expenses are fairly lean as it is at most payers. Obviously, there's always room for improvement and improving the operations of the plan. But I think most plans, when they're thinking of innovation, they're thinking of how do we keep our members healthier to reduce claims costs, or how do we work with our providers to think of new types of care services, so ACOs, for example, or bundled care payments, things like that, so they can kind of manage their risk. And that way, those savings would then be pushed over to the members with the idea of, requiring their members because their premiums would be lower.
Yeah, I mean, and the client I'm at right now, I mean, their big focus right now is that MLR ratio, right? They're just really trying to figure out the best way to keep your members healthy, but also to have better interactions with providers so that it's a closer connection, it's more coordination, and so it's really a continuum over a full spectrum of care, and full spectrum of health that they're managing, so that they can kind of lower the costs on the back end by really focusing on the front end of your care. So, I mean, any solutions around that, and I think health plans are looking for ways to better manage that medical loss ratio. Even though this looks nice now, that they're kind of within that ratio, usually they're completely outside of that ratio, and they're always looking to fix that. So.
Yeah, I just had a quick question on reimbursement claims, claims reimbursement. Now, is it standard for each and every ICD line, or does it depend on the geographic location, or depends on the provider?
Sorry, are you talking about the actual reimbursement amount? Is it tied to ICD-9, or is it?
Because providers always providers build something and the payers fight back and negotiate.
Yep.
And never understood that concept. So is there a standard fee for each and every ICD-9 code, or is it based on geography or payer?
So I think standard reimbursement is generally set by what the Medicare rates are. So usually the government sets kind of like the baseline kind of fee, and then from there, that's when the negotiations happen. They kind of go back and forth on what they actually want to be. But I think more often than not, the minimum you're going to get is that Medicare fee.
You're talking about managed care, which is private insurance, not Medicare.
But so, Medicare sets the standard. I think it sets like the baseline.
On a yearly basis, pretty much every plan will negotiate with every provider within their network to set the amount they're going to reimburse for each one of those ICD-9 or ICD-10 codes. And what Alec is saying is the base is set by Medicaid. The floor. Medicare? The floor, right? And then the plans like PCS Mass or Aetna would come in and say, okay, we'll pay this much more. Now, the amount that the provider actually would bill you if you didn't have insurance is even about that. So if you don't have insurance, you really get screwed.
So usually what happens is that it's that Medicare kind of baseline amount, and then everyone kind of tosses in their overhead on top of that, and that's where it starts to be negotiable.
And the more members you have within that provider network, the more members you have.
I see.
I just want to make sure that I understand the relationship between the 80% and you say that providers are going to want to cut their upfront costs, their claims costs as much as possible to be able to, and that's why there's an incentive for them to promote health in their users and so forth. But they wouldn't be able to cut that below 80% of what their claims are, right? So for right now, we've established that they're not really getting 10%, so they've got a little bit of room there to fill in to try to get up their 10%. Otherwise, if they get beyond that, they're going to have to, if they do reduce their payout, they're going to have to reduce their premiums then.
Right. So in a given year, if you're getting $100 of premiums and your claims are only 75, you would have to reimburse your members for $5.
Okay.
The incentive though for them is that they can actually then reduce premium charges on the next years and then get more.
Does that mean they mispriced in terms of looking at the pool of risks that they were looking at? Or did they do that intentionally?
Or does that ever happen?
I mean, higher operating.
I don't know exactly what the strategy is. More from the top.
Yeah. I know that it has. I mean, it's a new kind of mandate over the past couple of years. I think it started in 2012. So it's still kind of tweaking it. I know, especially for elderly folks, it's been much more common that they receive some sort of reimbursement because the risk ratio is much higher than when it's insured.
So how do you decrease when you said the contracts, then how do you decrease the claim reimbursement? You said payers are trying to decrease that claims reimbursement ratio. They're already in contracts.
Well, if you're a member of Aetna and they get you to live a healthier life through some sort of engagement or to seek out care at cheaper hospitals and things like that, they can reduce the amount that they can pay back out.
Can you talk a little bit more about like the detail of those negotiations that you mentioned between the payers and provider network? Like how detailed are they negotiating prices for particular services? Because as a consumer, you do feel like there's some fluidity in negotiation that happens during the year, which would seem like after they negotiate. So I'm just kind of curious what actually gets negotiated, what doesn't.
Because I think the biggest issue is that there's always a conflict or I don't want to say misunderstanding about what actually care is being delivered versus what's going to be reimbursed. And I think it's always a discussion around that. And so I think the default for a lot of times, which is kind of sad, for insurance plans is to kind of deny a claim unless it fits exactly in the box that you're saying. So, you did exactly what was part of the contract, exactly what was part of the kind of care plan. If you kind of deviate outside of that, more often than not, they'll deny that initially. And then that starts kind of the discussion and negotiation. We'll kind of get into it a little bit more. We kind of talk about the overall value chain, kind of the process within a health plan. But I think they tend to default towards denying and then having a conversation with your provider to really figure out exactly what they're going to reimburse after the fact. So, I mean, to get into the detailed contracts, I haven't really been involved in that aspect as much. But I think, once again, it's probably contract negotiations around the baseline parameters for things. And then the minute that you start going outside of it, that's when you have all the conversations and renegotiation after the fact.
So there's a little bit of regional variation because you're in New York City and costs are higher than they are in the
exactly.
So, just to piggyback off Alec a little bit, so what you're specifically talking about is if I go in for, like to buy cars or whatever, and certain particular
really, you pick that? That's only
person X is in my car, right? And certain procedures are done to them. With ICD-9, there's a lot more ambiguity in terms of what procedures were actually done. I don't remember specific examples, but definitely things like a knee replacement was very close to like an inner surgery thing. So there was a little bit more ambiguity. So payers did have the tendency to just deny the claim and then go back and try to figure out what service was actually provided. ICD-10 is much more specific. There's tens of thousands of additional codes in there that give you the ability to more in depth into what services are actually provided. I think the question you were asking was more on the negotiations that take place on a yearly basis to set the baseline price for each one of those ICD-10 codes.
Well, yeah, and just why, if that negotiation is taking place, why there still is so much needed negotiation down the road. So I think, collectively, you guys answered it.
Can I just have one thing added to it, too? That companies that are negotiating contracts with their insurer company will sometimes decide on different plans based on what the employer is able to contribute per employee and what they think their employees will be able to spend. So if you have, they might give you a choice of 3 plans. They might say you can go with a managed care organization or you can go with a point of service. And if you go with the managed care, your employee cost will be $50 and the employer will pay $50 to make up that $100 premium cost. But somebody may have a family and want to go with a family plan, and they may say, well, if you go, you have a choice of 3 plans. With this one, you pay very low deductibles, but you pay a higher premium. And every year, the company negotiates with the health insurer because they may offer different kinds of ranges in terms of price and deductibles. And in more recent years, sometimes the insurer might say, well, we will offer your employees a discount if they go to a health, like a fitness center. And they're like that. Or we'll offer dental benefits for an extra cost. So they play around with those kinds of benefits and services and deductibles.
That's actually an interesting piece too, because I know that there are also additional employers that will actually have specific restrictions on various diseases or actual conditions and have different policies around that. So that just further complicates the whole reimbursement issue. So if you go to the specific employer or provider, normally for everyone else, with let's say with BCBS MA, normally everyone's covered for a root canal, but for a very specific employer, root canals are not covered. So it just further complicates and makes things very, very customized and specific, which makes it difficult to do the whole reimbursements. And I know we kind of jumped into just talking about ICD-9 and ICD-10. Does everyone know what that means, or was that? Okay. Okay, because we kind of jumped into that. Sorry about that. Yeah, so ICD-9 and ICD-10, that's the coding around the procedures or the things that the physician will actually perform, and that aligns to kind of what the reimbursement on the back end with the insurance plan. So that's how they kind of communicate and how they coordinate and make sure that they're paying out the right things. And ICD-9 is like the standard developed by the government. So what ended up happening transitioning from ICD-9 to ICD-10 is that it started out as, let's say, like a couple thousand codes. Now it's tens of thousands of codes. So now it's very, very specific codes for ICD-10.
There's 20,000,
120,000. Yeah. I forgot the exact ratio. I know it's like small to a very large amount. But actually, a lot of people are complaining about ICD-10 being almost too detailed. It's like they actually have a code for a broken right wrist and a broken left wrist. I think it's getting to that level of specificity. So it's kind of good and bad.
Yeah, and the ICD-9 codes, like you're saying, are specifically related to the condition that the patient is there for. If you're talking about the procedures that they're doing, those are
CPT codes. Sorry.
And then they actually pay out based on the DRG codes. Which is and it's put them as a bundle. So if you've had a heart attack, for example, you're probably going to have a couple of ICD-9s and you'll have a couple of CPTs and you bundle them all together, and that's what they actually use to pay out.
And that's what the DRG is? Is the combination of those?
Combination of codes.
Yeah.
Everyone get that? Healthcare coding 101. All right. That was actually a really good discussion. You guys have any other questions or anything else?
What drives you to think that the innovation that's going to stick in the claim side of kind of consumer-facing stuff? When we look at like earnings reports or public company statements, they're getting hammered by their inefficiencies, and those admin costs are like. I mean, the discussion just quickly glanced over that and said that it's beyond that under control, but that's not the same reality I see. So, where do you see like the innovation play should be focused here? Like, where does that come from?
So I think, at least on the insurance side, when we talk about innovation being in that claim area space, I think that's innovation around managing health and promoting health. Because what's happening more and more is that, one, the plans are working closely and coordinating more with providers. Another piece is that they're actually now starting to develop episodes of care. I don't know if that's the term familiar with you. What's it called? Episodes of care.
Yes.
Where it's almost, you're now getting a provider will now get a bundled payment based on a full set of activities for, let's say, like a knee replacement. So the knee replacement also involves, physical therapy, and physical therapy kind of leads this and that, all of them being bundled as one payment. And to encourage coordination amongst providers, coordination amongst all the different physical therapists, the insurance plan will now pay out one amount and almost force providers to work together. So it really is focused more on lowering these costs by encouraging healthy behavior, encouraging health. And I think that's where I think the innovation play can be, because interacting with consumers, educating consumers, helping them kind of manage that piece. I think that's it.
And to piggyback on that, there's also the element that with healthcare reform coming in, there's a lot of pressure on payers to start interacting directly with individuals, right? So you have the exchanges coming to the market, and there's a huge fear from payers in general that these large employers are going to start dropping coverage for their employees. Once that happens, everyone has to go to the exchange. A health plan has to actually reach out to individuals and sell them on their plan versus everybody else's, right? So think about the exchanges kind of like Kayak for healthcare. Right? So you're able to actually compare every single airline and see what the flights look like in the same way that you're going to be able to do that with plans on the exchange. So from a plan's perspective, my admin costs have always been a problem, and making them more efficient is always been a goal and an objective. But the stuff that's very new is reaching out to individuals, reaching out, working directly with providers on these new types of care and care offerings. So that's kind of why, at least my opinion, is that with plans in particular, their real motivations for innovation are kind of geared more towards that side than they are from the admin side.
I mean, so that's a good point. And if you look at, what's the current thinking about this model? You mentioned health insurance numbers at that. It doesn't seem like they've done much. I don't know if they're still running it anymore, but that was a 2-year experiment, and what did we get out of it? That's not doing much to it. So what went wrong if you have thoughts?
I mean, personally, I don't know too much about the history of healthcare. Anybody else here? And the healthagen?
That was Aetna's innovation lab thing.
It's still going. I think they shut down CarePass, which is one problem.
Yeah, CarePass was
it shut down in December 31st.
So the question was of the history of healthagen. So healthagen was the creator. They were a small seed stage startup that created the iTriage app, and that's the asset that Aetna acquired. And then once they acquired them, then they started building a whole bunch of other things around it. But CarePass was separate from healthagen, though. So a lot of things that healthagen was doing was supposed to.
Well, I think healthagen is the umbrella that CarePass, and the ACS, which is Healthcare Solutions, which I think is where they're making most of their bucks selling to providers, which is a software company. And then iTriage is still, I think all of those they rebranded healthagen as a whole bucket of we're going to have consumer-facing software solutions, not necessarily.
Exactly, and their flagship happened to be the iTriage. That was just one.
There's a big difference between dealing with big, servicing large accounts as opposed to dealing with individuals. The cost of managing an individual goes up, everything.
Definitely. It's just something that
so you can see how the admin costs are flipping out of control.
So is it safe to say that 80% can be brought down by population health?
Yes, I think that's one aspect of one kind of lever that they use to kind of manage them.
So you mentioned how plans now have to engage consumers directly, and it's a more competitive landscape because it's marketplace, etc. So is all of that expenditure going into operating or admin, the fact that they're investing in these private exchanges to doing all this new type of marketing, and all the plans are extremely enforcement, especially national. I was curious how that, where does that fit in?
That would fit into
admin costs,
Yeah.
right? Okay.
How much is so? The ultimate goal is to lower 80% is to be cheaper on the exchanges, get more members, right? So there's a piece of this. I think a lot of health plans are struggling with brand equity for the first time. Like, you know, your employer knows you. That's great to have brand equity, bunch of HR reps or brokers, but now you need the average person to have brand equity. But that's like outside of this, it still has the same goal for adding new members. So where is that like another big bucket of innovation? So it sounds like the problem statements are all engage, and consumerism, right?
And part of that, yeah, is the brand equity side, right? So how do you make it such that your members or people in the community in general don't view BCS Mass or Aetna or whoever your health insurer is as just someone they can fight with if they're not paying their claim, right? I mean, that's the way that most of us interact with our health plans, or we get a fat bill every month. So how do you make them understand that the services that are provided by the plan and that it is a necessary service and they are actually doing something that's, you know, very good for in general, I think. But making that known within the community or within the general population is kind of attached to all of that.
Customer retention is going to be important because if you're able to deal with a certain group of customers and then they're pricing sensitive and they move away from you because of that fight over something that screws up your cost structure.
Yeah. Especially now that it's so easy. If your employer isn't providing your service, so your health insurance, then it's very easy to switch over to something else.
Yeah, I've been reading about a transition that's starting from a model where payments to providers are fee-for-service based now, but they're moving to a results based.
Yeah, value.
How's that going to affect?
So insurers are all about it because from the perspective of the insurer, if person X that got hit by the car goes in, and you know they, as a provider, you're incentivized, you know, obviously to get the best care possible, and you can justify, you know, giving an MRI, a CAT scan, every test under the sun. When if you're just going for fee for value, a lot of those tests might not be as necessary. And it's a funny thing when you just change the incentives, how much the actions actually change as well. And what they've noticed so far in a lot of these initial clinical studies is that results are actually improving and costs are going down.
Yeah, necessary tests don't actually improve results at all.
Yeah, but at the same time, providers are worried about liability as well. So
it pushes a lot. It starts pushing the risk onto the providers, which is why I think ACOs are going to be developed towards more of a partnership between both the payer and the provider, so that they are kind of sharing the risk and they're trying to understand the best way to mitigate all that. And actually, getting back to the fee for value, I think another area for innovation is trying to understand how to define that value. I think that's something that a lot of health plans, as they get into this new model, are trying to figure out. Like, how are we truly going to define value? How are we going to define results and the outcome? You know, because it's always much easier to measure output, right? And to reimburse on output.
Obviously, they have to come to a mechanism to average it across patients, because if you come to your provider at death's door and you die, it might be there might have been nothing that you do, but you know, if you come to them a lot healthier and you die, probably they made a mistake.
One way to put it, yes.